Greetings from IJA. I, Dr. Kiran Mahendru, will present original article from the November issue. It is on comparison of analgesic efficacy of ultrasound-guided external oblique intercostal plain block and subcostal tap block in patients undergoing upper abdominal surgery, a randomized clinical study. Upper abdominal incisions cause severe intraoperative and postoperative pain. Neuraxial techniques, being the gold standard for pain management, can be associated with complications. Therefore, interfacial plain block techniques have been identified as a part of multimodal analgesia techniques for upper abdominal surgeries with subcostal incisions. The options include subcostal transversus abdominis plain block, the quadratus lumborum block, and the rectus minor plain block. Limitations of these blocks are such as proximity to the operative field, technical difficulties associated with the depth of the anatomical target site, and infection or coagulation related contraindications. The external oblique intercostal plain block is a novel technique that blocks the lateral and the anterior cutaneous branches of the intercostal nerves from T6 T7 to T10 T11. The advantages of these blocks are the distance from the surgical site, the technical ease of giving this block, and the possibility of catheter insertion. The subcostal tap block is commonly used, but it spares the lateral cutaneous branches. The primary objective of the study was to compare the time to first rescue analgesia postoperatively in patients undergoing upper abdominal surgery via subcostal incision, receiving either external oblique intercostal or a subcostal tap block. The secondary objectives are the time of block performance, intraoperative and postoperative 24 hours opioid consumption, pain scores at 30 minutes, 1, 2, 4, 6, and 12 hours, patient satisfaction score, and any adverse events such as vomiting, sedation, pneumothorax, hematoma, and respiratory depression. The hypothesis was that the external oblique intercostal block would be more effective than the subcostal tap block in providing post-op analgesia in patients undergoing upper abdominal surgeries with subcostal incisions. It is a double-blind randomized control study conducted from March 2023 to January 2024, registered with the CTRI, including patients of ASA physical status 1 or 2 from ages of 18 to 65 years undergoing upper abdominal surgery with unilateral subcostal incision. The excluded patients were the BMI of less than 20 or more than 30, allergy to local anesthetics, infection at the site of injection, on chronic analgesic therapy, or inability to understand the pain scores or functioning of the PCA pump. Block randomization was performed using online software, and random allocation sequence was concealed in sequentially numbered opaque sealed envelopes that were opened on the day of surgery. The patients were divided into Group E, those who received ultrasound guided unilateral external oblique intercostal block using 25 ml of 0.2% ropivacaine, and the Group T that received USG guided unilateral subcostal tap block with 25 ml of 0.2% ropivacaine. An anesthesiologist with 25 such blocks experience performed the blocks. He was not involved in perioperative management and data collection. The co-investigator who conducted the case was blinded to the group allocated and the block given. The postoperative data was collected by pain nurses who were unaware of the group allocations. The patients were reviewed on the day before surgery and given the patient information sheet. The procedure, pain scores, and use of PCA pump were explained to them. The standard ASA monitors were attached and baseline parameters recorded. GA was given using fentanyl, propofol, and atracurium. Air oxygen sevoflurane mixture was used for maintenance and a MAC of 1 to 1.2 was maintained. Blocks were performed under strict aseptic conditions with ultrasound machines equipped with high frequency linear probe with a sterile sheath and a 22 gauge 80 millimeter echogenic needle. The Group E received the external oblique intercostal block using a high frequency linear transducer, which was placed in a parasagittal plane between the mid clavicular and the anterior axillary line at the level of the 6th and the 7th rib. Needle was inserted in plane from capillate to caudate direction to pierce the external oblique muscle and to deposit 25 ml of 0.2% ropivacaine between the external oblique and the intercostal muscle. In group T, scanning began in an oblique plane immediately below the costal margin. The transversus abdominis muscle was identified lying posterior to the rectus muscle. The needle was inserted in plane lateral to medial to lie between the transversus abdominis and the rectus muscle, and the same amount of drug was injected. The total duration of block performance was taken from placing of the probe till the injection of the local anesthetic. Skin incision was allowed 20 minutes after the injection of the drug. Any increase in heart rate or MAP more than 20% of baseline was treated with IV fentanyl bolus of 0.5 mics per kg. Total intraoperative IV fentanyl consumption was noted in both the groups, and all patients received dexamethasone 0.1 mg per kg at the start of surgery. Intraoperatively, hemodynamic parameters were recorded at 5, 30, 60, and 90 minutes after skin incision and at the end of surgery. The patients received IV paracetamol 15 mg per kg after induction and 6 hourly until 24 hours after surgery. At the end of surgery, IV ondansetron 0.1 mg per kg and reversal agents were given. The patients were connected to the PCA pump programmed for a demand-only mode with no basal rate. Boluses of IV fentanyl of 20 microgram with the 10-minute lockout interval were allowed, and a maximum fentanyl dose allowed was 120 microgram in a single hour. The primary outcome was the time to activate the PCA pump postoperatively, and the secondary outcomes were 24-hour IV fentanyl consumption, NRS measured when patient was asked to take deep inspiration at 30 minutes, 1, 2, 4, 6, 12, and 24 hours. The patient satisfaction score on a scale of 0 to 10, where 0 means least satisfaction and 10 is a maximum satisfaction at 48 hours after surgery. Adverse effects such as nausea, vomiting, and respiratory depression. Sample size was calculated based on a previous study comparing subcostal tap block with thoracic paravertebral block in patients undergoing open cholecystectomy. The sample size calculated was 25 required in each group, and SPSS 21 was used for statistical analysis. A total of 60 patients were assessed for eligibility, out of which 50 were randomized, with 25 included in each group. The demographic and surgical characteristics were comparable between the two groups. Now, coming to the primary outcome, which was the time to activation of PCA, it was statistically significantly different in both the groups. The patient pressed the PCA pump earlier in the subcostal tap group, that is at 409. Whereas the patients in the group E, that is the external oblique intercostal group, required the analgesic, rescue analgesic later as compared to the subcostal tap group. Also, the secondary outcome of 24 hours fentanyl consumption was also statistically different in both the groups, with the patients in the subcostal tap group requiring more IV fentanyl in the postoperative period. The patient satisfaction score was also higher in the external oblique intercostal group as compared to the subcostal tap group. Other parameters like additional intraoperative fentanyl consumption and block performance time were comparable in both the groups. Now, these are the intraoperative hemodynamic variation in both the groups, which was on the lower side in the external oblique intercostal group, but this was not statistically significant. Ultrasound-guided EOI block, that is external oblique intercostal block, significantly prolongs the time to first analgesic requirement. There was little difference in 24 hours opioid consumption and pain scores as compared to subcostal tap in patients undergoing upper abdominal surgery. The prolonged duration of analgesia in the EOI group led to better patient satisfaction scores. Now, the upper abdominal wall derives its sensory innervation from intercostal nerves from T6 to T10, and effective blockade of these nerves ensures adequate analgesia. Subcostal TAP block targets the upper abdominal wall but spares the lateral cutaneous branches of the intercostal nerves. A study conducted in two cadavers the authors found that the dye injected between external oblique and the intercostal muscle at the sixth or seventh rib covers the lateral and the anterior cutaneous branches of intercostal nerves from T6, T7 to T10, T11. The clinical finding that the time for first PCA activation was significantly prolonged in this group also reaffirms this finding. The incidence of nausea vomiting was not significant in either group. This might be because of use of multimodal prophylactic regimes like ondansetron and dexamethasone. No block-related complications were noted due to the superficial nature of the blocks. External oblique plane block offers advantages such as the ease of performance and needle or catheter entry away from the surgical site. Therefore, this block can be performed in patients with previous surgery having tissue scarring and obliteration of the subcostal plane. One major shortcoming of this block is the inability to provide visceral analgesia. The limitations of this study are that the EOI block, the external oblique intercostal plane block, was not assessed with the blocks that also provide visceral analgesia. They have given only unilateral blocks. Those studies suggest that there could be a sensory overlap in the upper abdominal innervation. Further studies comparing it with the rectus spinae or paravertebral block can be formulated. Surgeries with unilateral incisions were included. Bilateral blocks or continuous EOI blocks by inserting catheters should be studied in future. And further trials with larger sample sizes can validate their findings. Therefore, to conclude, external oblique intercostal plane block is an effective component of multimodal analgesic regime for patients undergoing upper abdominal surgeries. Thank you.